And can I shrink this thing up here? Let's see. Used to be possible to shrink this thing. Okay, so here is a guy who presented with some fevers, night sweats, and weight loss, and had this radiograph, and it didn't go away. So here's a couple of days later. Let's see. No, that was the 12th. Here's the 9th with our I think imaging in a different institution, but he's got nodules all over the place, and on CT he has these pretty crisp nodules in a random distribution. You know, I was thinking there aren't that many exactly along the fissures, but you can see that they do get out pretty close to peripheral surfaces here. And this was an AIDS-defining illness of miliary tuberculosis. So miliary TB as an AIDS-defining illness presentation, but this is one of the more dramatic miliary TB findings on chest radiographs, just nodules all over the place. Okay, so,
wow.
And then here's a dramatic chest radiograph of this patient transferred to us here with pneumopericardium, and it's confirmed on CT, which people don't believe chest radiographs, but there it is, nice pneumopericardium. There's some fluid in the pericardium here too, and they're bilateral pleural effusions. And then we get down to the abdomen, and it turns out that several years ago, there was a Roux-en-Y gastric bypass performed for weight loss. And this person came to attention because evidently she was weak and she passed out or something like that, was found by a neighbor, was brought in and stuff like that. So she passed out, she was hypotensive. She had endoscopy, and they placed a stent from her, I guess, distal esophagus to her jejunum through this gastric bypass. And for a while they eliminated the pericardial air, but then it came back a few days later. So they found, I think, on endoscopy that there was an ulcer that had eroded, I guess, at her gastric margin and stuff like that. Now, I do have some pictures from endoscopy that show contrast, swallowed contrast, ending up in the pericardium. I was unable to display those, but I'll have those. I'll be able to post those as JPEGs later. They wouldn't, these fluoro studies don't download, they don't display nicely in Osiris or Horos. So I have to get JPEG versions to do that. So this was a gastro-pericardial fistula as a result of an ulcer at one of these gastric anastomoses here. And a rather dramatic plain film here. Okay, so the nice thing about distinguishing pericardial air from pneumomediastinum is that if the air is in the pericardium, you get a big, broad black stripe that's very clean and empty, whereas if the air is just in the tissue planes in the mediastinum, it's just going to be composed of streaks, and you won't have a broad band like this. So if you see broadness and a clean, empty component, it's probably pericardium. And I think the coronal CT is good at showing just how high the pericardium goes in the mediastinum. It goes way up on the ascending aorta, almost to the brachiocephalic artery takeoff. So very nice distribution of where the pericardium is. Okay, and there was culture study. They found they found a little bit of candida, and but there was no infectious component to this. But they did have the person, I think, on voriconazole or fluconazole or something like that, because they did find a colony or two of candida. What were you going to say, Howard? I'm sorry I interrupted.
No, sorry. If you scroll on the coronal CT, there seems to be a little pouch of air if you go in the other direction that keep going in the other direction that goes towards, is that anything right? Yeah, about there somewhere?
Yeah, that was visible on cross sections too. There's a little component that was extraluminal, and there I think is the there's the jump.
Oh, yeah.
Glad you
Can you
pointed that.
bring that up? I think we've seen the gap, right?
I think we're seeing it right there.
Wow,
This is
so it goes right through the central tendon of diaphragm, which is fused with pericardium there, and the hole goes right through there.
yeah,
Wow.
good observation. Yeah. Okay, those are my two.
All right. Thank you. Who would like to go next? All right.
I'm going.
All right. I'll let. Let's see.
Okay, this one first is a really nice demonstration of what we've seen before on quite a few occasions when one has acquired systemic vascular supply to lung in the context of very chronic lung disease, in this case bronchiectasis. So I'll show you that we have radiographs that go back a long time, 1999, and undoubtedly before that. And you'll see soon that this is an area of bronchiectasis, or at least the most extensive area of bronchiectasis in this patient. I don't know if there is a particular predisposition to bronchiectasis, but certainly very chronic. So what I'll show you now is I'll bring up the CT with a coronal alongside it, and I will make both of these MIPS, something like that. And I'll scroll down. So obviously a lot of disease. Here is actually maybe more than one location in which we have more than one vessel arising from near the celiac artery and going upwards. So I'll bring that up, and you'll see on the coronal one and more, but particularly this one going through to feed the right lower lung here. So there's a tangle of vessels that end up in the area of bronchiectasis. That's quite remarkable. And then I also wondered whether, when I got to the surface of liver, in one of these images, I thought there were maybe, that some of these down here were maybe branches actually coming from hepatic artery branches in the liver right through the diaphragm. That's a little bit hard to say though. But I want to show you one interesting one. Obviously they're bronchial collaterals. And when I first looked at that, I thought, oh, here's a really nice teaching example of a big bronchial artery. But then I noticed that it seemed to keep on going up. So this is a vessel, for sure, but look where it arises, which is really interesting. So it actually arises from, let's see if I can pick that up right here. This is really curious. So it actually arises from kind of the base of the right brachiocephalic artery right there. See that vessel there? And that one, if I follow that one, it makes a big turn. It's this one. And then this one, of course, just goes down and supplies this area down here. So that is really curious. I'm not sure I've seen that before. But I suppose that you can get arteries coming from pretty much anywhere with chronic bronchiectasis or systemic arteries. I've never encountered this before, but I'm pretty sure that's what that is. It's coming from the aortic arch right there.
That's crazy.
Making that turn, and then it's huge and it goes everywhere.
Yeah, Howard, I think the ones you're showing from the abdomen are probably inferior pharynx rather than hepatic artery.
Yeah, I didn't have time to quite figure that out. Yeah,
I mean, maybe they come off the proximal hepatic artery, but once it gets into the liver, that would be really weird for it to
yeah, that would be
then
weird.
exit the liver.
More phrenics maybe, yeah. You can see this is a big fat pulmonary vein, so it's relatively big, but it doesn't have much contrast in it on the scan. So there's a lot of bronchial artery supply to this whole area, maybe slow flow, hypoxia, combinations of things. So that the amount of contrast medium, at least in that portion of the pulmonary vein, is almost not there, whereas this portion here, this pulmonary vein, contains more contrast medium. Maybe because that portion of lung is fed with this contrast medium from pulmonary arteries, whereas a lot of the blood flow going to this portion of lung is coming from all these collaterals. So the amount of opacification of this fat vein here is seemingly non-existent, relatively speaking. Anyway, kind of interesting physiology, but it's strange.
Right. Howard, when you look at cross sections of that right lung base, do you see abnormalities that look cystic?
In the parenchyma?
Yeah. Not really.
No, not particularly.
Okay. So, this is this chronic infection with neovascularity is the sort of thing that if there's a cystic component there, that sometimes gets called sequestration, particularly if it's, in a dependent lower lobe medially and stuff. And it's really that would be pseudo sequestration, meaning that the vascularity is acquired rather than factory installed congenital abnormal systemic artery.
Yeah, that's a good point.
Okay.
All right.
Okay, let me show you. This one is just a super nice demonstration of this, but it's something that, at least in the United States, we don't see very much, because we don't see very much very chronic left atrial hypertension anymore. So this person had surgery a long time ago for pericardial disease, but not cardiac valvular disease. So that was sometime in the past. And now we have, and I'm going to put these alongside each other because it's a beautiful demonstration of an enlarged left atrium, but a really nice demonstration of inversion of pulmonary blood flow. So here is a corresponding slab, and here you can see is a very dilated left superior pulmonary vein. It typically is lateral to the corresponding artery. And then on the right side, one can see and separate out the pulmonary veins. One's coming down here from the pulmonary arteries. And then, of course, it's easy to appreciate how big the upper lower pulmonary vessels are in relation to the lower lung zone vessels. So just and a huge left atrium. So the person has severe mitral incompetence from chronic pulmonary venous hypertension, one of the nicest inversion of pulmonary blood flow patterns I've seen in quite a while. And it makes a nice teaching case if you have a CT to show where the pulmonary veins are in relation to the arteries. So when you look up here, you can pick out the pulmonary veins, separate them from the arteries. So just really nice anatomy and a nice example of inversion of pulmonary blood flow, chronic pulmonary venous hypertension.
Do you think that MR was mitral regurg was the primary lesion that led to the left atrial dilation and the cephalization, or do you think that the cephalization?
That's the only one that I could. That's the only one that I could discern from looking at the medical record and the cardiac ultrasound to account for that.
Mm-hmm.
Yeah, it is pretty dramatic. Here is a really dramatic, nice example of sarcoidosis with multiple lesions, multiple lobes, showing the sarcoid galaxy sign. So There are many lesions that look like this. I'll make this a bit bigger in multiple lobes. You can see that you can actually make out patent bronchi traversing some of these. One of the bigger ones here is in the superior segment of left lower lobe, patent bronchi traversing their opacity. But many of the others have the halo of ground glass. But I think it's also a nice example, I think, of kind of a sarcoid galaxy sign or sarcoid galaxy-like sign of sarcoidosis. There are lots of enlarged lymph nodes.
Well, that one in the left upper lobe is a little funny. It's got it's got a lucency in it that's right there. It's funny.
Yeah, right there. I don't know
Yeah.
what to make of that.
You typically
Yeah.
don't see those.
Yeah, I don't know what to make of that. This is a pretty confirmed case of sarcoidosis, and
Yeah.
we have
I wonder if it
multiple
was related to
organs.
some just small airway obstruction.
Yeah, I don't really know. But she has skin lesions. She had a biopsy of stomach. She had granulomas in the liver, and then has this appearance. And yeah, there are lots of enlarged mediastinal nodes too, as well. But would you go for sarcoid galaxy sign or trying to make sarcoid galaxy signs?
Sure.
Yeah, I think so. Yeah, that is a bit funny there. Okay, the last one I'll do quickly is one of those cases where if the patient has findings of a fibrosing interstitial lung disorder, or at least chronic diffuse infiltrative lung disease, so this is not an acute illness, and this is in the context of an interstitial lung disease imaging conference, how would one characterize this? Now, from the point of view of the UIP issue of IPF, I think none of us would put this into either the UIP pattern or even the probable UIP pattern. It's neither of those. There you can see the distribution of disease. The lung bases are relatively spared. And then we see the distribution of these opacities. They are reticular opacities, but in some regions, there are even opacities away from the pleural surface in relation to bronchovascular bundles, perhaps airways. And either one would put this as indeterminate for UIP, but I think for UIP, or even indeterminate, these would be kind of odd. So maybe this would be that fourth column, which is kind of a non-UIP of IPF diagnosis, if that's a point of discussion.
Yeah, I would put this as not UIP. There's too many
non-UIP.
Too many funny things. I like indeterminate for cases that look an awful lot like UIP, but may not be clearly basal predominant, or there may be a borderline air trapping. I find that's what it's useful for. But I think your case nicely illustrates was probably, I would think, connective tissue disease. It looks like a mix of probably an NSIP and maybe some organizing pneumonia.
Yeah, I mean, it's really a hard case because the patient doesn't have a connective tissue disease, and there was no hint at what the diagnosis was. You talk about these patients, and then some number eventually go to a lung biopsy. So I'll show you the pathologist description. This is not really what I would have necessarily thought of particularly, but findings consistent with HP. So we have airway-centric pathology, the rare non-necrotizing granuloma, occasional multinucleated giant cell. Fibrosis is patchy, airway-centric, and subpleural. So the airway-centric points towards HP. Findings of inflammation, airway injury, and granulomas all argue against UIP. So there you are. I don't know what to make of it. Aspiration is a consideration when you see these basal lung opacities, but look at this statement. No aspirated material is identified.
So I presume she had no exposures based on your second paragraph there.
Yeah. Yeah. Curious, isn't it?
It is. All right.
But the more conferences we attend, the more used we become to being humbled. What's going on? Isn't it true?
All right.
Here's that description. There you go. Those are mine.
All right. Who's next?
I've got several.
All
I
right.
see Seth's on there and Peter's on there too. We won't show too many then. I'm going to skip that one for now. I'll show a couple of quick radiograph cases because I think these are always interesting, and I'll let you guys take a peek at this first and see what you think. Anything jump out to you?
Yep, there's a mogul with a main pulmonary artery lobes.
Yep, yeah, and trying to figure out how to get this stuff out of my way. It was blocking my screen with this new format. Yeah, here's the old study. So this is a patient who's in his 20s. I've shown a couple of these before. Eventually, patients with testicular cancer or some sort of germ cell tumor may go back to radiograph screening. Sure enough, this was the new finding. Here it is on the CT, and you can see there's the bump right there. So it's this AP window node. This was actually a primary non-seminomatous germ cell tumor of the retroperitoneum. And he was disease-free, and then this grew. And so they eventually took this out, and it was confirmed to be a metastasis. But I think that these kind of eye tests are important just to be able to recognize these abnormalities, because sometimes patients don't always get CTs. So that was a quick one. This one is, I think, a very illustrative case. And this is a patient who's in his 60s, never smoker, and came in with worsening left shoulder pain. So I don't have a chest radiograph, but I do have shoulder and cervical spine radiographs. And I actually just stumbled upon this yesterday because we were doing a restaging study of CT. And of course, I remember being trained and always tell my trainees, especially if there's any sort of shoulder pain or anything, always look in the superior sulcus. And it's often the things that are missing that are the hardest to see. And in this case, not only is there a soft tissue mass here that looks to be pleural or extrapleural or chest wall, but you can see on the frontal view of the cervical spine, here's the right first rib, left first rib is completely gone. I think what's also cool on this is that you see there's, who knows, he's not taking a big breath, but it does look like there's a few nodules here. And this does pan out on the CT. And I'll show you this first. So it's an expansile destructive thing of his left first rib. And he's got a bunch of nodules in a, I'd say random lower lobe. Some of them do cluster a little. Maybe you could argue perilymphatic. It doesn't really matter. It's all cancer. And so this was his presentation CT, no known cancer. And this all turned out to actually be metastatic colon cancer, presenting with a first rib metastasis as the presenting symptom. And here you can see that he's got liver lesions at this time as well. Interestingly, they never found the primary tumor. He had had a colonoscopy a couple years before, and they had taken out some adenoma, but it didn't have any cancer in it that they could find. But another nice subtle radiographic finding is a presentation of metastatic disease. Actually, this one. Jeff, you'll like this one. This is one the pulmonologist at the VA brought to my attention. It's just a patient who has some sort of dementia, worsening dyspnea, had a pulmonary embolism protocol CT, and you can see that looks like there's something in the airway here. It's low attenuation. It's even fatty attenuation here. And what's cool about this is you can see how much essentially air trapping there is in that right lower lobe just from this thing obstructing and overinflating the right lower lobe. So maybe there's a ball valve mechanism that whatever this is unable to allow air to really escape as effectively as it does everywhere else.
Is it a peanut?
Well, I'm going to get there quickly. Yeah. So, right. The point is, like, it's fat attenuation, but that doesn't mean that it has to be a mass, as we've shown many times. This was a year before, and you'll see there's nothing there at all. So it's not like it's a lipoma that's growing, because that was one of the questions, but he had an old study. There's nothing in there. And sure enough, here's the bronchoscopy. This is the remnants of a peanut. So you're exactly right on the actual cause. I think it's just important, as we've discussed many times, but everyone remember that vegetable material can be fatty attenuation on CT, so it doesn't have to
Are
be.
almonds fatty as well?
I don't know. I haven't seen an aspirated almond.
Because I have an aspirated almond and it's not fatty. So I'm
I think
curious.
the important thing is with these nuts, though, is the free fatty acids are quite irritating to the airways, and they cause a lot of swelling, and I think that's why they get stuck so easily, and you get the ball valve.
Yeah, but now we have to get into the nut versus legume discussion, since a peanut's not actually a nut.
You're right.
And an almond's actually the seed of the almond fruit. If anybody else has ever tasted it, it's a horribly bitter fruit. But that's a different discussion. Yeah, I don't know, Seth. And that corn kernel you showed way back, Jeff, was that fatty or not?
No, it was calcific almost.
So
yeah, corn doesn't have a lot of fat in it, so.
Let's see, which one? I'm going to show one more, I think, just because this is a good case. I think this shows where our value can come into play at tumor boards as well. So this is a patient who came to us in this fall, and they came from our interventional pulmonologist, and the pulmonologist said all these nodules are growing. This is the biggest one down here, and it was billed to us as being diffuse lung adenocarcinoma, and you can see some Cheerios here, scattered around in a few different places. So certainly this would be or could be a good look for a metastatic lung primary with just diffuse involvement of both lungs. The one thing though, and it maybe it wasn't on this CT, it's on one of the others, but I saw, when I was looking through this case, and this is around the time it was diagnosed, noticed this in the upper abdomen, and you can see there's no discrete mass, but you've got pancreatic duct dilatation and you've got atrophy of the tail of the pancreas. And of course, pancreatic cancer is going to be one of those ones that can mimic lung cancer when it metastasizes and can give you Cheerios. And so this patient had had a history of chronic pancreatitis, had actually had an endoscopy at an outside hospital the year before. And they thought they saw a mass, but they biopsied and it was just inflammation. So they chalked it all up to chronic inflammation. Well, when we presented this at tumor board, even though there was not much activity in the pancreas, and I told them I thought almost certainly this was going to be a pancreatic with lung metastases. And they did a bunch of stains and actually ended up doing 2 biopsies. The first one of a lung nodule, had a bunch of different stains. So all of these support a pancreatic cancer. The absence of TTF1 may argue in favor of a lung cancer, but then they ended up doing a repeat in a pancreatic biopsy, and this time did get pancreatic or adenocarcinoma, and so they thought the whole thing was probably a pancreatic primary rather than lung. But we've seen a few of these where the patients, don't have the mass biopsied or diagnosed prospectively, and it's only, after you take the whole picture into consideration. And I think that, we split up at the diaphragm. I think most places do now. It's always important to look, especially at the pancreas, when you see something that could be a lung adenocarcinoma, as it may be coming from the pancreas.
Interesting.
Yeah. So, all right. Well, Jeff, I'll stop there.
All right. Seth, Peter.
I can go if you want.
All right.
Okay. This is just a nice example of enlargement of the left atrium. One of the bigger left. This is an older chest X-ray too. And what's interesting here is not only is the left main stem bronchus is not just elevated, it's almost at a 90-degree angle, massive left atrial appendage. And you can also see this curvilinear course of the bronchus intermedius secondary to this huge left atrium. And on the lateral film, let's see, again, displacement of the bronchus intermedius, huge left atrium mitral valve replacement. This is a patient with mitral stenosis, but what wanted to show, she actually developed, oops, let me go back to this. She actually got, and what keeps happening, keeps coming into the hospital because now that chest x-ray was a long time ago. Now her left main stem bronchus is actually at acute angle, greater than 90 degrees, and it keeps obstructing and getting filled with secretions, and she keeps collapsing that left lung. So this is an old, let's see if I can find the old contrast study first. And also the other question, I'm curious if anyone knows this, I couldn't find any data on what, we've all seen huge left atria that are, and you can see here it is, compressing and squishing the left mainstem bronchus and filled with gunk. And we've all seen huge left atrium that are calcified. There's calcification in the wall. Does anyone know, and here's her, she has her valve replacement, both valves have been replaced, mitral and tricuspid. Does anyone know what the calcification in the wall represents? Is it atherosclerotic disease? Is it some other insult that leads to calcification in the wall? I've only seen it really in mitral stenosis.
So when I read about that decades ago, when that was an issue, when we still saw cases with that, because we don't see it so often anymore, it was attributed, it's a dystrophic calcification, and our argument was that it might have even resulted from the rheumatic inflammation that caused the mitral valve disease itself. So it's a dystrophic pattern, not an atherosclerotic pattern.
Okay. And this is an old, unfortunately, all the CTs we have recently are all with contrast. This is or without contrast. This is a non-con, and you can tell it's quite old. Whenever you can see, measure an EF from an axial CT, you can pretty much imagine that it's quite an old study, but nonetheless showing all the findings, but I won't belabor that case. Now, this is a very interesting case. I'm just going to show the images here. These are just movies because it'll be easier than going through a whole MR. So this is a patient with mitral valve prolapse and pretty severe mitral valve prolapse. Let me blow this up. And what one can see here is there's a condition that occurs with mitral valve prolapse that is associated with an increased rate of arrhythmia and supposedly some other issues. And it's very interesting. So you can notice here, so in most instances, and I'll show you an example kind of comparison case, when the left ventricle contracts, there is continuity between the myocardium and the mitral annulus. And here there's not. There's actually a pretty large gap between the posterior leaflet of the mitral valve and the left ventricle when it contracts down. And this actually has a term called mitral annular disjunction. And it's just not very commonly seen, and again associated with increase. And this is just beautiful. I love looking at this is a view in the left atrium, looking at the mitral valve and fosse, and as the leaflets billow back, you can see this huge gap due to severe mitral regurgitation. Let me see if I have another image of that mitral annular disjunction. That's just again showing the billowing leaflets from the mitral valve prolapse. And let me see here. Also kind of shows it here on the fourth chamber. You can see as the ventricle contracts, you can see that the anterior leaflet is still connected, but there is this gap here that develops, and it can be again associated with arrhythmias. This I'll just quickly show. That's not that exciting, just a 40 flow video showing the severity of the regurgitation. And just for comparison, I will pull up the I just downloaded a normal, this is not a normal heart by any means. It's an abnormal heart, but you can see that there's, even with this case, that there's basically no gap there between the myocardium and the mitral valve. So something I had not really heard of until I read a paper on it a little while back, but that was a nice example of that.
What do you mean by gap? Do you mean a stationary segment of myocardium? What do you mean by a gap?
I'm sorry?
What do you mean by a gap? Can you show the gap? What do you mean by the gap?
But you guys can't see can you not see
no,
my
I
arrow?
see it, but I was trying to
sure.
See what you were showing.
Here.
Exactly.
So when the myocardium, when the left ventricle contracts, normally, here, so when ventricle contracts, there shouldn't really be any gap, significant gap between the contracting myocardium and the mitral annulus. And here you can see that there is a fair amount of space it occurs in these certain cases of mitral valve prolapse where there's a certain space, and if it's over a certain length, I can't remember what it is, it gets termed as mitral valve disjunction, and it's associated with supposedly increased risks of badness.
So the myocardium has not contracted and moved anteriorly, it's bulging, as it were?
Well, the myocardium normally contracts, but usually there's continuity between that. I have to look up, would have to review to see. I think it's more abnormality in actually the valve and the annulus being losing its junction with the annulus. So here's the annulus, and there shouldn't be this gap here. This, I don't know, it's about, centimeter and a half, 2 centimeters. So if you look at any normal MRI or even MRIs in abnormal patients, you'll see that there's no, when the myocardium contracts, there's no real gap between these two structures. I can try to send out the paper. There's a nice paper, I think, in JACC describing that. It's just an interesting finding. This is a case of, really quickly, of a patient with scleroderma where they were looking for very severe pulmonary hypertension, as you can see, where they were looking for CTEPH, which there's not. And this patient has a lot of findings. There's some degree of fibrosis, presumably from the scleroderma, but also has these various nodules of different size. Now, these aren't the kind of nodules that this finding is chronic, these nodules. They've been there for a long time. These aren't that kind of periarteriolar blushing I commonly seen with patients with PAH, either secondary, primary, or associated with scleroderma. There are just too many. A lot of them are just these small ground glass nodules. And unfortunately, I don't have path on this case, but we're kind of thinking that. So it turns out that actually there are various forms of pulmonary hypertension or causes of pulmonary hypertension associated with scleroderma. And it's actually not uncommon to see PVOD or PCH in these patients with scleroderma and pulmonary hypertension. So I don't have path proof on it, but I was wondering if this could be a case of PCH/PVOD in a patient with scleroderma.
There definitely there are features of both, arguably, because I think the interstitial lung edema, albeit mild, and then the dominant finding of the central lobular nodules. So I think in terms of imaging, I think one can easily conclude that it's exactly that.
Yeah.
That both pathologies are present in the
process. I've seen plexiform arteriopathy. They look just like this, and there's not much in the way of edema, and these nodules are pretty small. With the PCH and stuff like that, you often have big ground glass patches, but these are fairly discrete, small nodules. Yeah. I think I don't think we can cross out plexiform arteriopathy.
No, it's possible. It's possible, but I have cases of PCH that look very, very similar, that are path proven, that look very similar to this, and it is right. To me, the stuff I see in PCH are usually either truly or just all within the central lobular or periarteriolar, and there are some periarteriolar areas of blushing. I wouldn't say they're not. It's just, to me, a lot of these nodules it's hard to put them all within the central lobular unit. But anyways, I think a lot of the majority are central lobular. I'm not sure, but that was just an interesting case. And then lastly, this is just a nice example of, again, we see a lot of CTEPH here, and this patient definitely has some CTEPH, some of her vessels, she has that, but her pulmonary hypertension is, you can see it's mostly distal disease, very distal disease. And, she was being labeled as CTEPH, but after kind of review of her hemodynamics, that this really isn't, this is part of it is CTEPH, but she actually is a combined, now kind of going over history, everyone believes she is a combined PAH and CTEPH. And we see a fair amount of combined patients here. And obviously, they try not to take these patients to surgery unless absolutely necessary, because they tend not, even with correction, they tend not to do as well than those with, obviously, with just plain old CTEPH, because they're lying disease. Yeah.
So Seth, is the thought that the PAH comes first and sort of the altered flow in the, maybe in the distal lungs? Do you see it typically with distal thrombus rather than proximal?
No, I've seen now like 3 cases where the patient gets labeled as this, and 2 of them have had distal disease, and the other one had flat out had,
I was wondering if some sort of distal
flow because it's a distal arteriopathy, and does it propagate upwards or something?
Right, like an in situ thrombus.
Yeah, and I don't have enough, it'd be interesting to look at. I'm sure if I went through their archives of how many thousands of patients, there'd be at least 20 or 30. And then also in the upper lobes, you may disagree. I just thought it had that, down here, there's clearly some segmental areas of mosaicism, but up here in the upper lobes, it has more of that kind of periarteriolar kind of pattern that I usually see with PAH, where you kind of see blushes around the vessels, but.
But the other thing that goes with it besides the blush is sometimes you'll see that there's actually a tiny little aneurysm. So the vessel suddenly gets a little bit larger, right?
Yes, and that's right. So that's interesting. Yeah, I called that the blush. So you call that, do you call those aneurysms?
Well, I think they're microaneurysms, but they often have a blush around them. So
yes,
I have a case I can show next week that has precisely that. You see there's a very crisp, enlarged part of the artery, and then there's ground glass around it.
I have seen that as well. I just, I see some things and wonder if I'm hallucinating.
So I think the blush up is a good description of the ground glass component.
Yeah. Okay, those are my cases.
All right, Peter, do you have cases this week?
Yeah, I got a few.
All right.
So the first case is we're consulted about it, about this CT, and basically clinicians came in and they told us this is a patient with a history of GPA, and they were wondering what we thought about the CT, because the patient was also immunocompromised. So the question was, is this infection? And it's not a typical appearance of GPA, so it's kind of a somewhat difficult to exclude infection on this. But if you look back, we look back at multiple other CTs, which actually weren't in the system at the time. But if you look at the initial presentation, this is what the patient initially came in with. So it looks like a very, so essentially like almost like a bronchiolitis, bronchopneumonia type of pattern, a lot of bronchocentric ground glass. And of course she was treated for infection the first few times, didn't improve. This is a follow-up, kind of a similar pattern. Eventually she was biopsied, and the biopsy was a little interesting. It was a multifocal vasculitis, but it wasn't. It kind of described it as a vaguely granulomatous inflammation of the vessels, but still most likely consistent with GPA. And then she was ANCA positive, so that's what the diagnosis was. The other interesting thing on the biopsy is that the pathologist also noted a bunch of small nodules, which were called meningitheliomas, which he thought, so he raised a concern for diffuse meningotheliomatosis, which I wasn't able to find any connection between Wegener's and meningotheliomatosis. But I thought it was just an atypical GPA. It's kind of waxing and waning.
Oh, strange pattern.
I don't really appreciate that many small nodules here. It's more just ground glass from the vasculitis.
So what you thought was peribronchial is actually probably periarterial.
Right. Yeah. Yep. Yep.
I've seen cases of GPA that I thought were airways infections. I mean, they had tree and bud even.
Yeah, and that's what I thought. That's what this resembles is exactly is a lot of tree and bud, but it's periarterial.
Cool.
Yeah.
Yeah, with the airway thickening too, sort of.
That's dramatic.
This was a case we saw yesterday. So it's a cardiac CTA. No, not much in the way of atherosclerotic disease, but there is a anomalous coronary here. The right coronary is anomalous. There's a inner arterial course, and then it's also narrowed. So it looks like it's probably intramural, which it could be. May require an unroofing to repair that. And then also, the patient has it's kind of an interesting hook'em with the septal hypertrophy, but then there's this, just the apex of the RV is also hypertrophied right there, while the rest of the RV wall towards the base looks more normal.
How often do you see RV involvement?
Not very often, actually.
Okay.
I want to ask you guys.
I've seen this pattern, exact same pattern, maybe minus the anomalous coronary, maybe 2 or 3 times. And we've all seen a lot of cases of HCM. So.
Yeah. So I wonder if we did an MR, if this would end up.
It does. It does.
Yeah, because it's so focal. Yeah.
I have a case of MR on it that does show the similar kind of hazy mid-myocardial enhancement.
And one last case. So this is the patient with the smoking history, and they have kind of this mixture of fibrosis and so CPFE essentially. So the most interesting part of this, the most important part of the scan, is this small nodule up here at this time. If we follow it on follow-up radiographs or follow-up CTs, so this was in March of 2019. So this is what he looks like in July of 2019. You kind of see, if you look at this nodule, it starts tracking inferiorly, almost like a vessel. So that's in July. This is the August scan. So you can kind of still see it tracking inferiorly, but it's more extensive now, more prominent. And then this was the most recent scan from January 9th. So there's this marked nodularity along the lymphatics. So this was a lung cancer that basically just spread. Had significant spread along the the lymphangitic spread along the right side. It involves it's a huge right hilar conglomerate there, and it might have also gone hematogenously in some nodules in the left lung, which also there. Not entirely sure if those in the left lung base are hematogenous or also it kind of look like they're tracking along the lymphatics, possibly there too.
This was an adeno-CA, right?
Yeah. Actually, I'm not sure. The biopsy hasn't come back yet, so I'm presuming, but I'm not sure.
Okay. Well,
it's interesting how it's spread along pleural surfaces quite a bit in that right hemothorax, and in relation to lobar fissure.
Yeah.
It's almost like a mesothelioma, somewhat mesothelioma kind of appearance. It's a lot of pleural disease. It's a strange progression.
Yeah, it must have seeded the pleura up at the apex and just spilled.
Yeah.
Main Hospital.
All right.
That's it.
All right, thanks, Peter.
Thank you.
Golf, room 710. Code MET.
Okay, let's see. You guys see my screen? Okay, so this is a case of a 41-year-old who was undergoing evaluation before a mitral valve repair. And let's get to a good series here. Let's try this one here. Yeah, here we go. So here's the right coronary, and you'll see there's this giant conus branch coming off, kind of pretty large one. And then you follow that, there's the right main here, pretty tortuous, quite large, and it goes off acute marginal branches, and then goes down here. And you'll see there's actually several branches supplying the inferior wall, the heart, and then there's the distal RCA there. If we come back up, you'll notice that there's really nothing here in the AV groove. There's no LAD left main out here. So this is a single coronary all off the right. And this was done because he had a cath before his, I think this is the right injection. Yeah, so he had a cath before his mitral valve, and you can see them trying to find the left here. There's nothing, and I think I've got somewhere in here. Here's a right coronary. So here you see the right coronary injection. It's a really big vessel, and it's just supplying the entire heart.
Mm.
So that was kind of cool. All right. This patient has long-standing pulmonary hypertension, has been followed in our pulmonary hypertension clinic. You can see the massive pulmonary artery. But what I want to show you is what's happening with the coronaries here. So we can see we got the right coronary coming off, but the left main is this really thread-like origin, and then you can see branching. And there is a mix of atherosclerotic disease, but also just very small vessels coming off there. And the thought is that this is being compressed by the pulmonary artery aneurysm. And I'll pull up the cast. So here's the right, and you can see a nice big right heart injection. Now when you go to the left, which I believe is this one, you can see just how, most of it's refluxing out. It's a very tight origin there, and then there is flow distally, but not a lot. And so this can be a problem. She's not a surgical candidate. My colleague Mark Schiebler did say there is I guess a cardiologist in France who does stent these patients, but this patient I don't think is going to get treated for this. But this is just another complication of a big pulmonary. We've seen bronchial compressions, but this is the first time I've seen a coronary.
Can you go back to the RCA shot again real quick?
Yeah.
Because what's interesting, I'm curious, sometimes, maybe in this case, I'm not sure, in a lot of these cases of really bad pulmonary hypertension, the guys here wrote a paper on it that you get coronary collaterals that actually fill
the bronchioles,
and almost go supply the right hilum. And I was wondering if that first one that goes out laterally goes off the screen is actually going into the right lung.
That's a good thought. I have a case of that. I saw one of those in, I have a couple fellowship. Yeah. But yeah, I have seen that happen before. Let's see. There's the right coronary. I've seen it come off the SA nodal branch, but yeah, it's a really small SA nodal branch, so I'm not seeing it. But
I showed one a couple weeks, but it's funny because they have casts which show it so clearly, and then we have coronary CTs, and you can't see it, and I don't understand.
Maybe it's the pressure of their injection.
Yeah.
All right. Let's see. I might be able to get all four of these. These are all nice coronary cases that Chris Francois shared with me this week. But so this is a cool case. So this is a young patient. She's I think she is in her 40s or something. She has a history of fibromuscular dysplasia, and she had a spontaneous coronary artery dissection on the left years ago. And so she underwent a bypass graft with a lima and was put on aspirin. And interestingly, her left main, actually the whole left coronary system reconstituted. And so the lima graft went down, but she presented again with some acute chest pain. And you can see the right coronary here. We'll get away from some of the artifacts, but you can see the lumen is very tiny. And then there's this eccentric soft tissue. And as we go down, I think we get a slightly better look at it. Yeah, there we go. So you can see here. So this is another spontaneous coronary artery dissection. And this one's going to be managed just with aspirin. it worked last time. But yeah, so the bypass graft, just an interesting teaching point that, you'll see this with vein grafts sometimes, and I think they do fewer grafts now, but I've seen a lot of grafts down with patent vessels because they just I think their threshold for bypassing is a little bit higher. So that's a sponge. I don't have our original CT showing the left side, but that was neat. And then this last one's a 71-year-old male who has a history of atherosclerosis, and I've got so many imaging series here. Let's try and find the CT. Yeah, here we go. But this is just up there with a list of monster coronary artery aneurysms. This is coming off the right. Now, this is after embolization was attempted. You'll see there's some embolization there, but there's still flow in it, and it does supply distally here. I can show you the cath. Let's see. We'll find the right. I don't know why Cyrix breaks these all up. That's the left injection. I'll find the right in a second. But as you can imagine, when they're injecting this thing, it's pretty much just turbulent flow. Here we go. That's a still shot. That's still left. There you go. So you see, it's just this big area, and you see the little turbulent flow in it. I've got an MR as well, but I won't bother showing that. Here they are trying to put some occluders in. You can see right there they have one in place, but they decided to terminate the procedure because it was didn't think they were going to be successful and didn't want to risk any complications. So, but it did actually shrink the size of the aneurysm a little bit, but it's still there. I don't know. I don't think I've seen one this big.
What do you think is contrast medium? What's calcium in relation to that whole thing?
That's a good question. Yeah.
Pretty chronic, I suppose.
Yeah. Let's see if I can play with the windows a little bit.
Gee whiz.
Yeah, I think the contrast is mostly this homogeneous stuff we see here. You can follow it back up. This little flow right there along the wall. I think some of this may be some leftover contrast. It could even be some contrast that's in the thrombosed portion after the procedure. I'm not sure because I don't have a non-contrast to know.
Right. Wow.
But yeah, so 4 nice coronary cases. I did want to. I have a minute here. I just want to show the absent left main. There's another interesting finding as well. You see, and that's this. Let's get the right about here. There's one more over. Yeah, there's this really big septal perforator that comes off almost off its own origin off the cusp there and passes right into the interventricular septum. You can follow it right there. Just a really juicy septal perforator. All right. Well, thanks everybody.
Thank you.
Thank you.
Thank you.
Thanks, everyone.
Talk to you next week.
Thanks, guys. See you.